I'm joined today by Dr. Eric Wallace. He's a faculty member at the University of Alabama, Birmingham, and medical director of their Telehealth program. Dr. Wallace, thanks for joining me today.
Oh, my pleasure. Thanks for inviting me.
Now, you've pioneered the use of telehealth for peritoneal dialysis patients. I'm a nephrologist, so I know that these are patients who do dialysis at home, and typically they have to come in once a month for a full visit to see how they're doing. How can you accomplish this remotely?
Well, it was one of the things when I was designing the program. I didn't want anybody to think of telemedicine as inferior to an in-person visit. So the way I designed the program was that whatever we accomplished in person, I wanted to accomplish remotely. So for those non-nephrologists out there, what I needed to accomplish, I needed to talk to the patient. The patients on peritoneal dialysis actually keep detailed records of everything they do on the therapy, including vital signs, blood pressures, ultrafiltration values, which is how much fluid they remove. So I needed to be able to examine the flow sheet. Next thing, I needed a physical exam. So, you know, in the nephrology world, the biggest thing is trying to determine someone's volume status. So I needed to be able to listen to their heart and lung sounds. I needed to listen to their abdomen sounds. Examine the exit site, look for pitting edema. Finally, I needed to be able to do labs because once a month we get in-person labs, which is key to actually managing the dialysis patient.
So I think I can imagine how the auscultation works. I know there are, Bluetooth stethoscopes and things like that that can transmit the sounds to you, but something like edema, which is, a tactile, hands feeling the legs type of thing. How can you do that over a video conference?
So the way we do edema is the medical provider, which in this case is a nurse at the county health department, will actually hold a handheld digital camera pointed at the patient's leg and push for 15 to 30 seconds. And then I can actually see the pitting on my end. But it does help with very trace edema. The nurse is right there who knows how to examine a patient for swelling and lets me know right then and there.
So I think that you brought up this issue of having them present to a healthcare facility, in this case the county health department. I would imagine a lot of patients would love to have this happen at home. What's the limitation there? Is it billing, or are there more technological limitations getting this directly into a patient's home?
Well, there's a couple of considerations in how to do this at home. So billing right now is probably one of the biggest ones, which is right now Medicare, which is about 80% of the dialysis population, does not allow for any of the originating sites. Originating site is defined as where the patient is during one of the telemedicine visits. So Medicare does not support that type of interaction. But there's some other problems with doing a visit at home, which aren't insurmountable, but they are some barriers. So first of all, one of the things that I think is most important in a monthly dialysis visit is the labs. So how would someone on peritoneal dialysis get their own labs? And there's ways to do this. So one way is you actually send the nurse to the patient's house to draw labs. The other way is the patient actually goes to, say, their primary care provider, who then draws labs and ships them.
So you mentioned the physician's pocket here, so I'll chase that for a second. Let's say I'm a physician, I'm interested in providing this service to my patients. What's my motivation? Can this be a revenue driver for my practice, or is it purely for patient convenience? How do you work it into your clinical practice where people are actually seeing you in person?
The harder question is, let's say you don't have that model. I mean, what's in it for the physician? Well, another thing that could be in it for the physician is these physician practices that actually spend a large portion of their day actually with windshield time, so driving to and from different locations. So if the billing model was right, it would actually prevent some of these time frames where the physician has to drive significant distances to get to their patient, which makes the physician more efficient and actually gives the patient more time with their physician, not less, because now the physician can leverage the 2 or 3 hours of driving time to that patient to actually to spend with patient care as opposed to behind a steering wheel. There's lots of questions that I don't necessarily have the answer to right now. Right now my fundamental driver was the patient, but it does take me longer to do a telemedicine visit than an in-person visit. So if you're a physician who is already full with multiple overbooks, you're definitely more efficient by keeping those patients, seeing them in person, because you can line them up and now they're waiting for you. You don't have to wait for someone else on the remote site to put the stethoscope on the patient's chest. So if you're a physician who has no room for extra patients, telemedicine may not be the right move financially. On the other hand, if you're a physician that has extra time, you don't have enough patients, you are having to drive 4 and 5 hours to fill your days, well, maybe that is where telemedicine actually does make sense.
So, Dr. Wallace, what data do we have on the patient's experience of this in terms of their satisfaction? Is this something that they embrace? Is it convenient but maybe not ideal? How do they find it?
Oh, well, my patients love it. In fact, after the study, so many of my patients, so the study that started this was 6 months of standard of care followed by 6 months of telemedicine. And then the patient is off study because when I designed the program, Medicare had not adopted the 90966, which is the home dialysis bill, as supported by telemedicine. So I only designed it as a 12-month study, but after the study, all of my patients who finished the study want to go back on telemedicine. They keep on asking me, when can we do this as a routine? And right now at UAB, we're in the process of getting all the pieces in place so we can do billable visits, which also have their own hurdles, specifically getting through IT firewalls, et cetera. But probably in April, this month actually, I'll be able to do some of these actually just as standard of care and not as part of any study. But I think the satisfaction speaks for themselves when all of them come up and say, when can I go back to telemedicine?
So take us away from nephrology for a moment. Where do you see this going next outside of dialysis? What are you looking to do at UAB? And if you can speculate, nationwide more broadly, where are we going to see this used?
Well, so where I see it for UAB in Alabama is nothing short of transforming how we give care. If we can do this for a home dialysis patient, which is probably one of the most complex visits, I'm sure we can do it for virtually any type of care. And the question really is, it's where is this best served? And so I think for the start, where my start is, because aside from home dialysis, I do rare genetic kidney diseases, and I think that in a university setting, probably where the need is most is what is the care that can only be done at universities. And I think that's where the country as a whole needs to start. It's what are the rare things that are only taken care of at one place that right now we're forcing patients to drive hours to come get care. I think one of our first stops after nephrology is actually transplant. So nephrology transplant at UAB has been at the forefront of this, saying when can we start as well, and my hope is also by the end of April or May they'll start doing some of their pre-evaluation visits and actually post-transplant follow-ups using telemedicine. I think what you'll find in studies to come is that the no-show rates of patients who live far away with transplant is going to go down significantly, because now we'll be able to go to the patient to check their labs, communicate how their transplant is doing. So my hope is that long-term that's going to translate into better transplant outcomes. But it's not just nephrology transplant. At UAB we have liver transplant, heart transplant, lung transplant. There's other diseases. Cystic fibrosis is another one that probably the care should be done at the home, because as soon as you get those patients into a clinical environment, into a clinical waiting room, and you know how much infection there is in clinical waiting rooms, things like lung transplant and cystic fibrosis, probably we should transition the care to the home where they're not exposed or not having to come out into waiting rooms to be seen. So rare disease, I think, is something that we probably should have focused on 10 years ago with telemedicine.
Well, Dr. Eric Wallace, you are the director, the medical director of telehealth at University of Alabama, Birmingham, and thank you once again for spending some time with us today.
Oh, my pleasure.